little bit of a specialist subject, type 1 diabetes, isn't it? I think quite a few of you here are GPs and practice staff, I think, so you will be coming into contact with type 1s at some point. I'm a GP. I'm also a medical advisor for diabetes.co.uk, and we're just about to launch a program for type 1s to help them to have the option at least of low carbohydrate stroke ketogenic type of diet. So why are we talking about type 1 diabetes in respect to metabolic health? Well, I'm going to try to show you that I think that metabolic disease is just as important in type 1 diabetes as type 2 diabetes, even though type 1 diabetes, you could argue, is just a straightforward hormone replacement therapy. So we've all had the nightmare of being rung up on a Friday evening and the patients ringing you up because they can't get hold of the community diabetes nurse or their team, and their blood sugar's 22 and they're feeling a bit sick, and they're at the airport and they're about to travel through 5 time zones, and what should I do, doctor? And it's Friday night and it's a bank holiday and you're my doctor, so I need some advice, please. And when they're not doing that, they're always going hypo and in hospital, and when they're not hypo, they're always going into DKA, and when they're not going into diabetic ketoacidosis, when they're not going into that, they're swinging around with sugar control all over the place. And in fact, only 3% of our type 1 diabetics, of which I'm one, are achieving the target guideline of 48 millimoles per mole, which is way above the guideline for people who don't have diabetes, which is 42. So yeah, it's a difficult situation all round, really, isn't it? And then they get sent on to Daphne courses to learn how to eat bread and cakes and how to monitor their carbohydrate counting based around that. And so they're much more confident in injecting much more insulin, and the insulin helps them to put on weight, and they put on more weight and they get more swings of blood sugar. And then what happens is that they start to get complications, they get amputations, blindness, strokes, heart attacks, kidney failure. Exactly the same conditions that type 2 diabetics get. So I think it's no accident that type 1s end up, even though they start off with a different disease, that they finish off with pretty well the same disease. And I'll try to show you why. Okay, so all I'm trying to show is that if most people have heard of insulin resistance. Yep. Everybody heard of insulin? Basically, insulin resistance is when you inject more and more insulin to get the same effect. So for some reason, our bodies become resistant to insulin, and that's part of the metabolic syndrome. So if you eat a load of carbs, eventually those carbs have nowhere to go, and the liver gets fatty, and et cetera, et cetera. So if you think about type 1 diabetes as a hormone replacement therapy, which is essentially all it is in type 1s, because essentially type 1s, aren't they, just lost their pancreatic function due to whatever process, so you have to inject insulin, and that's it. But the only problem is that insulin is a highly complex hormone which has many interactions, and it's difficult to balance the insulin with the carbohydrates. So if you just look at all I want you to do is to look at that one and that one. So this is a study where they looked at, I think it was about 20 people, no, it's less than that, 14 people with diabetes. They're all relatively young. Most of them have had diabetes for an average of 12 years. And their HbA1c was about 7.5%, which is not bad, really. And they're all youngish, 20s, 30s. And they compared those with people who had no diabetes, and they put them all to sleep and did measurements on them through a cannula. So the people with diabetes are the black dots, and the people without diabetes are the white dots. Now, the glucose level here is the diabetic control throughout the night. So it starts at about 2300 hours and goes on to, God knows what, goes on to 6:30 in the morning. So you can see that in a person with type 1 diabetes, their glucose level's not bad, 7-ish, 6-ish, but it's above that level of a non-diabetic. You'd probably expect that. But now look at this. That's the insulin level in the blood throughout the night. So I think that's Lantus, or a long-acting insulin, so it's gradually wearing off in amount. But if you can see, it isn't really having a huge effect on the glucose. And it's very high level. So this person, over 12 years of diabetes, has got hyperinsulinemia, and they're relatively well controlled. The only thing that might be interesting to you is this here is leptin levels. Now leptin tries to stop you eating, doesn't it? So leptin's trying to help you to survive by trying to tell you not to have your porridge in the morning because your insulin levels are very high. And also your thyroid levels are very high as well, or relatively high in comparison. Sorry, thyroid levels here. So type 1 diabetes ends up as a metabolic disease over and above a hormone replacement therapy, which is a bit of a disaster really, isn't it? And this is a paper, you don't need to worry too much about this, but essentially they took some people with no diabetes at all and injected them with glucose or saline and measured the amount of insulin required in order to normalize the sugar level. And they found that after just 40 hours of using insulin, they needed more insulin in those people who they were injecting glucose into. So after just 40 hours of high sugar levels, there was more insulin required, and that was an insulin-resistant state. So what we're doing is causing double diabetes, which is, some people have probably heard of double diabetes, and it's iatrogenic. It's induced by physicians and clinicians, and it's caused by the treatment for type 1 diabetes. And there's one way around this, and that is actually to reduce the metabolic load on the body. And the way you're going to do that is to cut down the amount of insulin the body needs. If you have a metabolic syndrome, of course, you'll be eating less carbohydrates, so you'll need less insulin to handle those carbohydrates. If you have type 1 diabetes, you'll be injecting less insulin because you're going to be eating fewer carbohydrates. And over time, and it does take time, you will eventually end up without insulin resistance, but it can take a long, long time. It can take 18 months or so on a very, very low carbohydrate diet in the ketogenic range, which is just pure fat burning down to about 30 grams a day. So type 1 diabetes ends up as type 2 diabetes, and it can be managed very easily with a low carbohydrate diet. So if you go on to diabetes.co.uk, if you're clinicians and register your interest in the type 1 program, you'll be able to help your patients out in the longer term, and they'll do very, very well. And a lot of them will end up in the normal range of glucose control rather than the fairly average 48 to 56, which we're getting in most people at the moment. That's it. Thank you.
Thank you, Ian. That's brilliant. And it's great to have Ian along because, one, he is the most knowledgeable person I've ever met around type 1 diabetes, and I've learned a huge amount off him. And two, in our healthcare system, we do blur type 1 and type 2 diabetes quite often. And I'm not aware ever of, when we've been talking about type 1 diabetes, of a focus of the importance of metabolic health in type 1. The way we've been treating it is just creating this absolute inexcusable disaster. But we keep our prescribing of insulin up.